Hello, I'm Parul Tandon, a gastroenterology resident at the University of Toronto. I would like to welcome you to our inflammatory bowel disease educational video series sponsored by educational grants from the Canadian Association of Gastroenterology and AbbVie Canada. These videos were developed to target critical issues in IBD that are routinely encountered in inpatient and outpatient care. Recent published evidence suggests that Canadian gastroenterology trainees are not fully satisfied with the level of IBD exposure under the current training model, and several topics appear to be inadequately covered during training. As such, our aim is to provide a comprehensive update on core and complex inflammatory bowel disease topics to improve trainee knowledge and overall confidence levels. We plan to do this by interviewing Canadian inflammatory bowel disease experts in an engaging and interactive format. The target audience for this program includes gastroenterology trainees and early career physicians managing patients with inflammatory bowel disease. This program is an accredited self-assessment program under Section 3 as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada and approved by the Canadian Association of Gastroenterology. Each module is approved for 2 hours of Section 3 credits for a total of 6 credits for all trainee modules. Please remember, the accreditation expires March 15, 2022. The Mount Sinai Hospital and University of Toronto Division of Gastroenterology allow for the posting of the program for educational purposes only. The information, dialogue, and included slides are presented by faculty specifically selected and recognized as national experts in the field. The content of this program is to be used for educational purposes only, and the participants of each video assume no liability for the information herein. This is video 2 of the series. We'll review the key principles around the identification and management of perianal Crohn's disease. Management of perianal disease is complex, and recent evidence suggests a large variation in practice, likely due to lack of generalized consensus among physicians. Though over 70% of Canadian program directors view the medical and surgical management of perianal Crohn's disease as an essential IBD competency in GI training, only 30% of trainees report confidence in this topic. As such, it is important to try to summarize the current literature in a concise manner. The objectives of today's talk are to discuss risk factors for perianal Crohn's disease, to discuss the various phenotypes for perianal disease, to discuss the different classification schemes for perianal disease, to discuss the diagnostic algorithm for detection of perianal Crohn's disease, to discuss how to assess the severity of perianal Crohn's disease, and to discuss the medical management of perianal Crohn's disease, abscesses, fistula, and strictures, with the focus on achieving perianal fistula healing. Joining us for this discussion will be Dr. Hiliary Steinhart, an inflammatory bowel disease expert and gastroenterologist from Mount Sinai Hospital in Toronto, Ontario. Dr. Steinhart is a medical lead of the IBD Centre and professor of medicine at the University of Toronto. He is also the co-first author of the recently released Toronto Consensus Clinical Practice Guidelines for the medical management of perianal fistulizing Crohn's disease. So who better than him to educate us on the complexities of perianal Crohn's disease? Well, welcome, Dr. Steinhart. Thank you for joining us today for educating our viewers on the very important topic of perianal disease in Crohn's disease.
Thank you. Thanks for inviting me. I look forward to an informative and interesting module today.
Okay, so let's get started. So why don't we start off with describing to our viewers why this topic is so important and why we're here today to educate them on this.
Perianal Crohn's disease is a well-described and often poorly managed complication of Crohn's disease. It consists primarily of perianal abscesses and fistulas and was first described by Penner and Crohn's back in 1938. The prevalence of perianal Crohn's disease is said to be on the order of about 26% after 20 years of disease duration. But in certain phenotypes, the rate can be as high as even 90%, particularly in patients with distal disease such as proctitis. Now, oftentimes, perianal fistulizing disease can be a marker for a more severe disease phenotype and can be associated with the need for recurrent surgical procedures, poor outcomes, and significant psychological and physical morbidity. Perianal disease can be associated with severe symptoms such as perianal pain, discharge, and this can lead to impairment in quality of life, sexual function, and associated psychological and physiologic disturbances. And as a result, it's very important that physicians treating patients with inflammatory bowel disease be aware of the possibility of perianal fistulizing Crohn's disease in their patients, detect it early, and institute appropriate therapy so as to avoid some of the long-term complications.
So why don't we talk about sort of the risk factors for developing perianal disease and what should tip off a physician that a patient may have perianal Crohn's disease?
Well, some of the symptoms that can be associated with perianal fistulizing disease are pain, swelling, or discharge in the perianal area, and any suggestion of that should stimulate the clinician to think about the possibility of perianal fistulizing disease, do an appropriate assessment, and if necessary, further investigations to detect the presence of perianal fistulizing disease.
So can you comment on specific risk factors for developing perianal disease?
As mentioned before, the location of the luminal Crohn's disease is a strong risk factor for perianal disease, with rectal involvement having the highest risk for perianal fistulizing complications, whereas ileal disease or isolated ileal disease probably has the lowest risk for perianal complications. Other risk factors for perianal disease include age, with younger age of onset of disease, particularly below 40 years of age, being higher risk than older age of onset. As well, there have been studies that have suggested that gender may be a risk factor, with females having a somewhat lower risk than males, but this hasn't been borne out in all studies. Finally, there appears to be a genetic predisposition to the development of perianal Crohn's disease. Individuals with the variant of IBD5 gene on chromosome 5 appear to have an increased risk of perianal Crohn's disease. The NOD2 CARD15 gene doesn't seem to be associated with risk of perianal disease per se, but does seem to affect responsiveness to antibiotic therapy. Interestingly, smoking hasn't been found to be associated with perianal Crohn's disease, but certainly it is important for patients with Crohn's, as it does seem to increase the severity of Crohn's disease in general. Finally, the microbiome may also play a significant role in perianal Crohn's disease, but this hasn't been specifically worked out. But based on empiric observation that diverting ileostomy results in significant improvement in perianal disease, it would suggest that the microbiome does play a role.
Okay, so younger age, perhaps male gender, and distal disease are risk factors for developing perianal disease. That was a great summary. So let's move on to sort of the phenotypic classification of perianal disease. Could you describe to our viewers how perianal Crohn's disease can manifest?
That's a great question. Perianal Crohn's disease can manifest in several different ways. It's important to recognize each of them because in some patients, perianal disease can be the first manifestation of Crohn's disease, and it'd be a clue to underlying Crohn's disease for the clinician. Some of the ways that perianal Crohn's disease can manifest are as follows. Skin tags can be seen in up to 37% of patients with Crohn's disease. They are large, hard, violaceous or cyanotic protrusions of the perianal skin arising as a result of lymphedema of the tissues secondary to lymphatic obstruction. Excision of these tags is generally contraindicated because of problems with wound healing. The second type of skin tag is the elephant ear tag, which is a flat and broad tag that is usually painless. Hemorrhoids do occur, but seem to occur less often in patients with Crohn's disease as compared to those without Crohn's. A recent study reported a prevalence of only 7% in patients with Crohn's. However, patients with other forms of perianal Crohn's disease, such as skin tags, are frequently under the impression that they have hemorrhoids. Often this diagnosis is mistakenly given by their physician. Anal fissures are tears or splits in the distal anal canal. They can become chronic if they persist longer than 6 weeks. Non-Crohn's related fissures are often posterior located and thought to be due to poor blood supply in that location. Fissures that occur in patients with Crohn's disease are thought to result from direct ulceration due to the underlying disease process. They can be asymptomatic, can be located in the anterior position, and are often present with other perianal disease. They will spontaneously heal in about 80% of cases. And finally, perianal abscesses can occur in up to 80% of patients over the course of their lifetime with Crohn's disease. Perianal abscesses often present with the acute onset of pain and typically require urgent surgical evaluation and drainage. Many of these do not heal after draining surgically or spontaneously, and this in turn leads to development of externally draining fistulas. Fistulas are abnormal communications between the rectum or anal canal and the external perianal or ischioanal skin. They generally arise from perianal abscesses and can be associated with recurrent abscesses and continuous or intermittent drainage. Over time, damage to the anal sphincter mechanism due to repeated local sepsis from abscesses and fistulas can lead to fecal incontinence.
Okay, so speaking of perianal fistula, could you describe the various ways we have to classify the different types of perianal fistula in Crohn's disease?
Sure. There have been several classification schemes that have been derived to classify perianal fistulas. One of the most commonly used one is the Parkes classification scheme, based on observation by Parkes and colleagues in the 1970s and a number of patients undergoing surgical procedure for perianal fistulas. What this system does is describe in the coronal plane the relationship of fistulas to the internal and external anal sphincters. There are 5 broad categories of fistulas within the Parkes classification system: intersphincteric, transsphincteric, suprasphincteric, extrasphincteric, and superficial. With this classification, the presence of any branching or any crossing of the fistula midline, anteriorly, or posteriorly, called horseshoeing, must be indicated. In simple terms, over 90% of perianal fistulas are either intersphincteric or transsphincteric. However, the Parkes classification system is often difficult to remember, and as such, the AGA has proposed an empiric and easier approach to the classification of perianal Crohn's disease. By this classification, fistulas are classified as either simple or complex. Simple fistulas are low superficial, low intersphincteric, or low transsphincteric in origin, have a single external opening, have no pain or fluctuance to suggest a perianal abscess, have no rectovaginal fistula, and have no evidence of anorectal stricture. These fistulas are more likely to heal than the complex fistulas. On the contrary, complex fistulas are high, with high intersphincteric, high transsphincteric, extrasphincteric, or suprasphincteric course, and may have external openings, are associated with pain or fluctuance suggestive of the presence of perianal abscess, associated with the rectovaginal fistula, may have an associated anorectal stricture, and may be associated with the presence of active rectal disease at endoscopy.
Okay, so that was a great summary on the 2 classifications that are available. Let's move on to the diagnostic assessment for perianal Crohn's disease, particularly talking about imaging modalities available. Could you comment on that?
Sure. But before we talk about imaging, I think it's important to emphasize the importance of history and physical examination in identifying those patients who may have perianal Crohn's disease and who may benefit from imaging. Often the presence of perianal disease can be tipped off by a careful history and physical examination. In a patient in whom perianal disease is suspected, we can then think about imaging studies. And the imaging studies are important to detect the presence of perianal disease, look for fistulas, fistula anatomy, look for evidence of an abscess or collection that may require a surgical drainage or intervention. In addition, there have been studies that have suggested that using imaging criteria as an outcome for treatment of perianal Crohn's disease can result in better long-term outcomes than using clinical criteria alone to assess response to therapy. One would think that a fistulogram would adequately delineate all of the fistula tracts and would be a useful modality for patients with perianal Crohn's disease. However, there are limitations, and not all of the tracts can necessarily be filled by instilling contrast material into the fistula openings. As a result, the actual ability of the fistulogram to delineate the fistula anatomy and determine the fistula type according to the classification systems is relatively low, and sensitivity has been described as being somewhere between 16 and 50% with fistulograms. The imaging modalities most commonly used to evaluate perianal Crohn's disease are endoscopic ultrasound and MRI. The endoscopic ultrasound involves putting a probe into the anal canal and emitting a high-frequency sound wave that can provide both 2D and 3D images of the anal sphincter anatomy as well as fistula tracts. And in fact, fistula tracts can be better highlighted by injection of contrast, in this case hydrogen peroxide, into the fistula tracts. One of the landmark studies done by Dr. Schwartz and colleagues and published in Gastroenterology in 2001 aimed to determine the relative accuracy of endoscopic ultrasound, MRI, and examination under anesthesia in the evaluation of perianal Crohn's disease fistulas. The accuracy of each of the three modalities was over 85%, and the accuracy approached 100% when two modalities were combined. The investigators concluded that all three tests, EUS, MRI, and examination under anesthesia, accurately delineated fistula anatomy in patients with perianal Crohn's disease, and that the optimal approach may be combining any two of the three methods. However, it is unusual in clinical practice to use more than one modality in a given patient for a single episode unless the first modality does not provide adequate delineation of the anatomy. Other studies have shown that the pelvic MRI examination has a diagnostic accuracy that ranges from 76% to 100%, whereas the diagnostic accuracy of the endoscopic ultrasound ranges from 56% to 100%. The sensitivity of endoscopic ultrasound is up to 87% and the specificity 43%, and for MRI, sensitivity rates are as high as 87% and specificity as high as 59%. It is important to recognize that T2-weighted MRI sequences with fat suppression are optimal for fistula imaging, whereas gadolinium-enhanced T1 weighting helps to differentiate fluid from pus from granulation tissue. As such, both our consensus group and the AGA technical review both concluded that endoscopic ultrasound and MRI are appropriate and sensitive and accurate modalities for the detection of perianal disease in patients with suspected perianal Crohn's disease. The choice of the modality that one would use depends upon factors such as local expertise and availability of the technology or technique, as well as some technical factors such as the presence of anal rectal stricture or possibly the presence of implantable devices that would limit the use of MRI.
Okay, so you mentioned Dr. Schwartz's study looking at the exam under anesthesia. Could you further comment on the role of an EUA in the management and diagnosis of perianal Crohn's disease?
Historically, the examination under anesthesia has been considered the standard of care for the investigation and management of patients with perianal Crohn's disease in whom there's a high index of suspicion of an underlying perianal abscess. That index of suspicion is based on features such as local pain, fever, or fluctuance of the area on physical examination. One of the advantages of the exam under anesthesia is that it allows the institution of therapeutic intervention if an abscess or collection is found. This could include placement of a non-cutting seton or a drainage of an abscess. And in patients who have medical therapy initiated, it is important to have drainage of sepsis, source control of sepsis, whether it's through placement of a drain or a seton, that should be done prior to initiation of effective medical therapy.
So in addition to the imaging modalities, is there a way to grade the severity clinically of perianal fistulizing Crohn's disease?
There have been attempts to develop an index, a disease severity index, similar to the Crohn's disease activity index that's used in patients with Crohn's disease who may not have perianal disease. A group in McMaster University in the mid-1990s developed the Perianal Crohn's disease activity index in order to use it for patients in perianal clinical trials as a outcome measure in those trials. The score evaluates severity based on 5 criteria: discharge, pain, restriction of sexual activity, type of perianal disease, and degree of induration, using a 5-point Likert scale ranging from no symptoms to severe symptoms. At this point, no large study has validated its use in a large population of perianal Crohn's disease, and as such, what the optimal therapeutic target is not known, and the differentiation of mild from severe disease based on the PCDAI score has not been determined. However, the index can be used as a baseline screening tool to help frame the discussion regarding the urgency of starting treatment.
So the management of perianal Crohn's disease is often multidisciplinary, and surgeons are often involved in the management. Could you comment on when a surgeon should be consulted for the management of perianal Crohn's disease? Is it always?
Well, not always, even though we like our surgeons. There are some cases where surgical intervention is necessary. Our guidelines state that in patients with perianal fistulizing disease, surgical consultation should be considered where there is a suspicion of underlying sepsis or abscess, or in patients who haven't achieved an adequate response to medical therapy for their fistulizing disease. Surgery is useful, as mentioned before, for the drainage of abscesses or areas of sepsis, and it has been shown that surgery in combination with medical management can augment the responses to medical therapy and improve long-term functional outcomes in patients with perianal fistulizing disease.
I think staying on the topic of surgery in perianal Crohn's disease, it gets quite confusing for a trainee to understand the different surgical options available for perianal fistulizing disease. Could you briefly comment on a few of the techniques available?
Sure. The selection of the appropriate surgical technique is based upon the fistula anatomy. It's based upon the presence and severity and location of the luminal disease activity, particularly if there's rectal involvement, as well as the presence or absence of abscesses. Furthermore, the paradigm has shifted somewhat towards the use of combination of surgical therapy along with medical therapy in order to improve healing rates over the long term, as well as improve functional outcomes in patients with perianal fistula. In a patient with a clinically suspected perianal abscess based on clinical features, an exam under anesthesia with abscess drainage is the appropriate first step in management. Waiting for an imaging study to evaluate the presence or absence of an abscess in that situation is likely not warranted and would only delay definitive treatment of the patient and potentially impact upon their long-term outcome. At the time of exam under anesthesia, loose draining setons can be placed to allow the fistulas to remain open so they can drain and thereby prevent further abscesses from occurring. This is important to remember because when one considers medical therapy with the intent of closing a fistula, the setons must ultimately be removed since the fistula will never truly close as long as the seton is in place. The other type of seton that a trainee should be aware of is the cutting seton. This type of seton is only rarely used in Crohn's disease because as it is tightened, it cuts through the anal sphincter and results in a significant incidence of fecal incontinence. As a result, it's only very rarely used in only very specific circumstances in the treatment of perianal fistulizing Crohn's disease.
So we've talked about the diagnostic algorithm for detecting perianal Crohn's disease and the ways to sort of classify the severity. Let's move on to management. Could you walk us through the algorithm that your team has recommended in the recent guidelines for management of perianal Crohn's disease?
Sure. I think it's worthwhile discussing the different modalities individually and then concisely discussing how those can be used in combination to manage perianal fistulizing disease. Our guidelines suggest that in the initial management of perianal fistulizing disease, antibiotics can be used to achieve symptomatic response while waiting for more definitive treatment to be instituted. Metronidazole and ciprofloxacin allow for control of perianal sepsis, decrease in fistula drainage, and they can be used alone for simple fistulas. In complex fistulas, prolonged therapy is required, which increases the risk of adverse events. The current evidence for antibiotics suggests that the use of antibiotics for 4 to 12 weeks significantly improves fistula drainage. Furthermore, when used in combination with anti-TNF agents, antibiotics achieve symptomatic remission more frequently than with anti-TNF therapy alone. This is 65% with combination therapy versus 33% with anti-TNF alone. Unfortunately, there are no data to support the long-term use of antibiotics, particularly when other therapies are continued. A practical point that is important to remember is that if a patient is intolerant to ciprofloxacin or metronidazole, then other antibiotics with excellent tissue penetration, such as clavulin, can be used. The use of immunomodulators such as azathioprine, 6-MP, or methotrexate for the treatment of perianal fistulizing disease is not recommended. This is largely because we just don't have any prospective trials for the use of thiopurines for perianal fistulizing Crohn's disease, especially now when we have other, seemingly more efficacious and rapid-acting treatment options. Immunomodulators are not used routinely as monotherapy for perianal disease. That being said, their use with biologics such as anti-TNF may prevent immunogenicity and improve anti-TNF drug levels.
So we've talked about antibiotics and immunomodulators. Where do anti-TNFs sit in the algorithm for managing perianal Crohn's disease?
Well, anti-TNF therapy is still currently the best available treatment that we have for the treatment of perianal fistulizing disease. This is based on the pivotal clinical trials that were performed initially by Dr. Present and colleagues in the late 1990s, and then subsequent studies, including the ACCENT-2 study with infliximab and the CHARM study with adalimumab. The study published by Dr. Present was the first to demonstrate that infliximab monotherapy resulted in a significantly increased rate of fistula healing. 90% of Dr. Present's study population had perianal fistulas, and the primary endpoint was fistula response, as determined by a 50% reduction in the number of draining fistulas using gentle pressure on clinical examination. This response was observed in 68% of the infliximab 5 mg per kilogram group, compared to only 26% in the placebo group. Dr. Sands then conducted the ACCENT-2 trial. This trial importantly demonstrated that the use of infliximab resulted in complete healing of fistulas, in other words, no drainage, in 35% of patients at 54 weeks, compared to 19% in the placebo group. Other subgroup analysis of larger trials, such as the CHARM study, have demonstrated sustained fistula healing up to 2 years after adalimumab induction and maintenance therapy.
So certainly promising results from those pivotal studies, but in the ACCENT-2 trial, the rates of fistula healing at week 54 were only 36%. Could you comment a little bit further on that?
This certainly stresses the severity or aggressiveness of perianal fistulizing disease. The fact that only a third of our patients achieve adequate outcomes or healing with our best therapy, in other words, anti-TNF therapy, really underscores this fact. This raises the possibility or the need for other approaches, more creative or imaginative approaches to the management of perianal fistulizing disease. One of those approaches may be combination therapy, and this may be combination therapy of medical with surgical management. It may be anti-TNF therapy with immunomodulators, or maybe anti-TNF therapy with antibiotics. There's very little data regarding each of those, but some data has suggested some improved outcomes. With the use of immunomodulators, the improvements may be due to improvements in the pharmacokinetics of the anti-TNF therapy with reduced immunogenicity and higher drug levels. However, this overall is an area of future research that I think we'll see more work done in the future.
So you touched upon immunogenicity with immunomodulators and anti-TNF inhibitors. Could you comment on therapeutic drug monitoring, as it seems to be such a hot topic in inflammatory bowel disease in general, and how that plays a role in optimizing fistula healing for patients with perianal Crohn's disease?
I think we're just starting to figure that out. There have been a number of studies that have been reported either in abstract form or more recently as full papers that have looked at this particular issue. The emerging theme that we're starting to see is that it appears that higher drug levels are needed for patients with perianal fistulizing disease than for patients with luminal disease in order to obtain optimal treatment outcomes. There's been conjecture as to why this may be. One of the reasons that has been proposed is that you need higher drug levels in order to achieve deeper tissue penetration with the drug in fistulizing disease. So far from the evidence that we have, median infliximab serum concentrations appear to be much higher in patients who achieve perianal fistula healing compared to those who do not. Infliximab levels that have been proposed as potential targets range from greater to 5 to greater than 13 micrograms per milliliter. The problem that exists is that all of these studies have varying definitions used for fistula healing or response and still remain relatively small. So the take-home message is to consider the administration of more anti-TNF therapy in patients who've had a partial response in order to determine if giving more anti-TNF can result in better outcome and fistula healing. The other key aspect to remember is that therapy should not be discontinued once fistula closure is achieved, because discontinuation of therapy is associated with a high risk of recurrent fistula.
Okay, so we've talked about anti-TNF. Could you comment on the evidence available for treatment of perianal fistulizing disease with vedolizumab or ustekinumab?
It's still too early to say whether either of those treatments are effective, and as a result, they're not included in the treatment algorithms at present. There hasn't been a dedicated study of vedolizumab or ustekinumab for the treatment of fistulizing perianal Crohn's disease, but in the large registration trials, a number of patients at baseline had active draining fistulas, and subgroup analyses of those trials have suggested that a proportion of those patients did experience fistula response. So still, we need more information and more studies to clearly define the role of these drugs in fistulizing disease.
So now we've talked about the surgical management as well as the medical management of perianal Crohn's disease. Sort of the new advancement in this field seems to be mesenchymal stem cell injection locally into perianal fistulizing tracts. Could you briefly touch upon that for our viewers?
Certainly there's a lot of optimism and enthusiasm about the use of stem cells injected into fistula tracts to improve healing rates. There's been a clinical trial that's demonstrated that mesenchymal stem cells improve healing rates in patients with perianal fistula. These are non-hematopoietic multipotent stem cells that can suppress the immune response and result in healing of inflamed tissue. They also have been shown to encourage proliferation of regulatory T cells, thereby limiting the immune response. They were first shown in 2003 by Garcia Olmo and colleagues in Spain to cause successful healing of a rectovaginal fistula. Subsequently, the same group conducted phase 1 trials, phase 2b trials involving 49 patients, comparing fibrin glue to fibrin glue plus adipose-derived mesenchymal stem cells, and showed that fistula healing at 12 months was significantly higher in the stem cell group versus the fibrin glue group, with an improvement in quality of life. Other studies have demonstrated similar results. The other type of stem cells that can be used are autologous bone marrow stem cells. Overall, this is promising, but further studies are needed to determine where stem cell therapy fits in the algorithm of the management of perianal Crohn's disease.
So an exciting outlook for the future. Well, Dr. Steinhart, thank you so much for joining us and taking the time out of your busy schedule to educate our viewers. Any parting words for our viewers on the management of perianal Crohn's disease?
I just want to underscore that it's really a severe disease phenotype that can lead to significant disability. And I always tell the residents and trainees that a patient with bad perianal Crohn's disease, bad perianal fistulizing Crohn's disease, is the most difficult type of Crohn's disease patient to manage, and often the most miserable patient in terms of their quality of life. So it is an important area for us to manage well.
Well, thank you again.
Thank you.